This program is brought to you by Emory University.
It's my pleasure to introduce Gina Lundberg, who is an associate professor and clinical director of Emory Women's Heart Center and a preventive cardiologist who practices out of East Cobb, St. Joe's, and Executive Park. Dr. Lundberg is very active at the national level at the AHA and ACC and also in the NLA. She is very active on social media, as all of us know. And she's truly an advocate for women and heart disease and really enjoys teaching. And she's going to talk to us today about utility of lipoprotein A for cardiologists.
Thank you, Dr. Mehta. Hopefully you guys can all see my slides right now. So we'll get started. So I have no disclosures. I'm briefly going to take you through a lot of information on Lp(a). We'll discuss the guidelines and the enhanced risk factors, the properties of Lp(a), how can you use it clinically, studies specific to Lp(a), and then a few of the controversies associated with it. So Lp(a) or lipoprotein (a) has been around since 1963. It was described by Berg. In 1978, Stevenson and Zamnick suggested the idea of created the antisense oligonucleotide-based drugs to treat this. So this is an idea that's been coming for a long time. In 1989, we were using nicotinic acid to lower Lp(a) levels, but that didn't translate into improved outcomes. In 2016, the European Atherosclerosis Society and the European Society for Cardiology added Lp(a) as a risk factor for atherosclerotic cardiovascular disease. And then in 2018, the American Heart Association and American College of Cardiologists added this to the management of blood cholesterol guidelines. And then everyone knows in 2019, in the primary prevention guidelines for cardiovascular disease, it was added as an enhanced risk factor. So at that time, it was really very exciting because things such as conditions specific to women, rheumatologic and inflammatory disorders were added, and so was Lp(a). And it suggested that Lp(a) levels above 50 milligrams per deciliter or 125 nanomoles per liter constitutes an enhanced risk factor as well. The National Lipid Association also has a position paper on Lp(a) stating the importance of it as a biomarker for not only cardiovascular disease, but calcification and aortic stenosis and other cardiovascular disease. They indicate that it's a high-risk marker for myocardial infarction, ischemic stroke, atherosclerotic stenosis, and aortic valve stenosis, specifically calcified aortic valve stenosis. So I'm going to give you two examples of the clinical cases where this might be informative. We have a white male born in 1965. His father had a fatal myocardial infarction at age 40, so a strong history of premature coronary artery disease. The man had an LDL of 171 in 2003 and was started on statins. It was felt that he was inconclusive from familial hypercholesterolemia, but certainly suggestive. And on a statin, he's maintained his LDL between 70 and 100. He had a calcium score in 2019 with a total score of 5, which only put him in the 50th percentile for risk. Our other case is an African-American female who was born in 1978. Her father had his first myocardial infarction at 38. Again, strong family history for premature coronary artery disease. There's also a history of diabetes, hypertension, and lipids. She had a calcium score at age 40 that was 0, and her LDL has been 82 milligrams per deciliter. And so her ASCVD lifetime risk score is 27%, but her 10-year risk is only 0.1. Her HDL is quite good at 94, and triglycerides are good at 66. And so her physician told her she did not need to start statins at this time. We will come back to these cases later. So is this enough? Are we doing enough for these two patients with these strong family histories of cardiovascular disease? Well, what we know about Lp(a), it is a known association with cardiovascular disease and calcified aortic valve stenosis. It's an independent and genetic risk factor for cardiovascular disease. It's likely causal for cardiovascular disease and calcified aortic valve stenosis. And it's elevated above 50 milligrams per deciliter or 125 nanomoles. And this puts the patient in the 80th percentile for elevated Lp(a). Lp(a) has three important properties. It's pro-atherogenic, pro-inflammatory, and pro-thrombotic. And these are the three things I really want you to remember today. Lp(a) is simply an ApoB 100 moiety with an ApoA attached. It's then secreted into the circulation where it can affect the carotid arteries, coronary arteries, aortic valve, kidneys, and peripheral artery disease. The LPA locus determines the ApoA levels, which determines the circulating levels of Lp(a). It's highly polymorphic in size with over 40 ApoE isoforms varying in different individuals and different populations. It's more potent than LDL cholesterol, PCSK9, and 9p21 for genetic risk. And it's one of the strongest monogenetic risk factors of all. And so here's a graph showing basically this is the level of risk with PCSK9. This is for LDL receptor abnormalities, ApoE. And then here's Lp(a), much stronger than all of these known entities for cardiovascular disease. This is a graph showing men and women from a large Danish population looking at the different levels of Lp(a), and this is how the risk was determined. So you can see below 5, this is basically undetected and no risk. Below 30 is still starting to be low risk, but above 30 there starts to be risk, particularly in women, but also in men. Above 85, the risk increases, and above 119, the risk is greatest. So as the Lp(a) level increases, so does the risk. This is a map showing that Lp(a) is found across the world. It's found in North America in about 20% of our population, and that's 73 million people. A little less in Latin America, about 20% in Europe, about 30% in Africa, 25% in South Asia, 10% in Asia, and 20% in Australia and the Oceania Islands. This is from the Inner Heart Investigation Study looking at different ethnicities for risk of myocardial infarction, specifically looking at myocardial infarction in patients with elevated Lp(a). And this was very informative because it showed African Americans did not seem to have an increased risk for myocardial infarction, while South Asians, Southeast Asians, Latinos, and even Chinese had higher risk. The study was also important because it looked at the different isoforms of Lp(a), and it showed that elevated concentrations of Lp(a) were associated with significant risk of myocardial infarction in all populations except the Arabs and the Africans. It also showed that the isoform size was not as important as we had thought, and that the risk was independent of isoform size, and also gave us an added risk for why we're seeing so much cardiovascular disease in the South Asian population. The clinical implications were that this is an important biomarker regardless of isoform size, which has been one of the criticisms, and that therapeutic agents to target Lp(a) need to be evaluated for clinical use. Lp(a) is also an important risk in women, which you all know is an important thing to me. Lp(a) increases in women at the time of menopause. So this is probably one of the few areas where you would want to check an Lp(a) level a second time in someone's life. One of the benefits is Lp(a) is because it is entirely genetic. It can be checked once, and if the level is low, it doesn't need to be checked again. But likewise, without a therapeutic target with a medication at this time, there's no reason to keep repeating an elevated Lp(a). The one place where you might want to recheck is a woman who had a level approaching 30 to 50 prior to menopause to see if it escalates to a higher risk level after menopause. We know that oral estrogen replacement can attenuate the rise in Lp(a) in a postmenopausal woman, but this was not seen in transdermal estrogen replacement, which we feel is the safest for women in general. Some studies have showed the cardiovascular risk reduction with estrogen replacement in women with the highest levels of Lp(a), but keep in mind currently estrogen replacement or menopause hormone therapy is not recommended for cardiovascular disease risk reduction in women. The HER study, the estrogen progestin replacement study, showed Lp(a) reduction with hormones was beneficial in a high-risk group of women. Lp(a) is an independent risk factor, and estrogen and progestin lowered it. There were large reductions in the Lp(a) levels for women with decreasing risk for recurrent coronary heart disease events. Interestingly, the women with the highest Lp(a) levels showed lower rates of coronary heart disease events in the hormone-treated group, where women with low levels of Lp(a) showed higher CHD rates with the hormone-treated group. These were the Lp(a) levels for women in the study, and as you can see, most of the women had lower levels, and as predicted, about 20% of the women had higher levels. And this is the graph showing all subjects who were taking hormone replacement versus placebo. And for all subjects, overall, there was only a mild improvement with hormones in the 2 to 5 year range. The women with the lowest Lp(a)s did not show any benefit with hormones, but interestingly, these women with higher levels of Lp(a) showed the greatest benefit with hormone therapy. But again, we do not recommend hormone therapy for postmenopausal women. AIM-HIGH was a large study looking at Lp(a) and specifically evaluated niacin in the reduction of Lp(a). And this is the graph of lipids, LDL below 70, LDL 70 to 99, and above 99. So this is where we would keep most of our patients with known coronary disease, and this is the level where younger, healthy, few risk factors would be kept. And then here's the level of Lp(a), and it was divided by quartile. So green is the lowest quartile, red is the highest, actually it's a tertile. And as you can see, even in low LDL patients, having an elevated Lp(a) put them in a much higher risk group. And with higher LDL levels, the Lp(a) was still higher. So even in people considered low risk with low LDL, if they have the Lp(a) in an elevated range, they still have an increased risk of atherosclerotic cardiovascular disease events. So what about niacin and Lp(a)? And I still get asked this question periodically. This is the data from AIM-HIGH. This was Arbiter 2, Arbiter 6. These large studies really put to rest any idea that niacin or nicotinic acid was beneficial. So here is the odds ratio with pretty much everything falling on the below one side. So no real benefit in niacin or nicotinic acid with elevated Lp(a). And it makes people feel bad. So I generally try to dissuade patients from wanting it, even though it's over the counter. Here's another interesting and helpful thing that Lp(a) can do. It can help reclassify intermediate risk patients. This was a group of 826 patients, and these had no known cardiovascular disease, but Reynolds risk score was in the intermediate zone, and these 41 had evidence of cardiovascular disease. Using Lp(a) elevation to reassign classification, they found in the lower risk group with no cardiovascular disease that 40 patients could be reclassified into a lower risk group, and 13 patients were reclassified to a higher risk group. Likewise, in the cardiovascular disease cases group, 4 patients could be reassigned to a lower risk group, while 11 patients remained in the highest risk group. So this can be a helpful determinant if you're trying to decide, is the patient really lower or higher, or do I want to add additional therapy or go to a higher level of therapy, such as a PCSK9 inhibitor. Lp(a) levels are also associated with coronary artery calcium scores, particularly in asymptomatic individuals with a strong family history of premature atherosclerotic cardiovascular disease. So this graph is showing the percent of patients with a calcium score above 100. This graph is showing the calcium score based on percentile and above this 80th percentile. And most of us who read calcium scores believe that above 75th percentile is high risk. These are the patients with the lower Lp(a) levels versus the higher. And as you can see in both sets with a calcium score above 100 or above the 80th percentile, more of these patients have elevated Lp(a). And as I said earlier, Lp(a) is associated with calcified aortic stenosis. With more calcification, you get higher peak velocities and more density of the valves. It also makes them less likely to be amenable to TAVR. I have found that checking Lp(a) levels in patients who are starting to develop moderate or moderate plus aortic stenosis helps me determine how long I want to wait. Because if TAVR is not an option with more calcification, we want to move ahead sooner than later. So when you're looking at Lp(a) and predicting acute MI, calcified aortic valve stenosis, or risk of cardiovascular disease, 1 in 14 patients with an elevated Lp(a) will have an acute MI. 1 in 7 will have aortic valve disease. Men with elevated Lp(a) have higher risk of calcified aortic valve stenosis, while women have a higher risk of coronary artery disease. And Blacks or African Americans with elevated Lp(a) have a greater risk of cardiovascular disease, but not myocardial infarction, as we learned from the InterHeart study. So, should we be testing for Lp(a)? So these are the current recommendations from the NIH LBI working group that were established in JAC in 2018. It is wise to check Lp(a) in patients with a family history of premature cardiovascular disease or themselves having premature cardiovascular disease, in patients with familial hypercholesterolemia or strongly suspected FH, patients with a family history of Lp(a) elevation, patients with recurrent cardiovascular disease despite optimal medical therapy, and patients who have greater than 5% 10-year risk of fatal cardiovascular disease using the pooled cohort equation or the SCOPE algorithm. So these are the treatment options for Lp(a). And interestingly, statins can increase elevated Lp(a) levels while reducing LDL seems to be the main target. Nicotinic acid, as I told you, is no longer recommended because while it lowers Lp(a) levels, it does not improve outcomes. Lipoprotein apheresis is recommended for this in high levels and is more commonly used in Europe, particularly the Netherlands, but only a few patients receive lipoprotein apheresis for elevated Lp(a) in the United States. PCSK inhibitors and the antisense oligonucleotides, mipomersen is one of them. And this shows you the ASOs are the most important for reducing risk. No risk really with statins, it may improve. Niacin has a 20 to 30% drop, apheresis a 30 to 35% drop. But our real hope is here in the ASO medications currently in drug therapy and trials. So the Fourier trial, as you all know, looked at the PCSK9 inhibitor injection drugs, and this specifically looked at evolocumab versus placebo. And they found that the median baseline level of Lp(a) in Fourier was 37 nanomoles per liter. And what they found was patients with lower Lp(a)s had fewer cardiovascular events on evolocumab in both median and below median levels. And this is cardiovascular deaths, MI, or urgent revascularization. Again, evolocumab improved not only Lp(a) levels, but improved outcomes. So the Fourier conclusions were that higher levels of Lp(a) are associated with an increased risk of cardiovascular events in patients with established cardiovascular disease, irrespective of the LDL lipoprotein cholesterol levels, and that evolocumab significantly reduced Lp(a) levels, and patients with higher baseline Lp(a) levels saw the greatest benefit. 33% of the patients had markedly elevated Lp(a) over 120 nanomoles or greater than 50 milligrams per liter. And the median Lp(a) reduction was 27%, but in the highest quartile, it was only 16%, thus suggesting that higher levels are even more resistant to reduction. And each doubling of Lp(a) level was associated with an 8% higher risk of cardiovascular disease. Patients benefited from Lp(a) reduction regardless of their baseline LDL levels, and with elevated Lp(a) levels, LDL in the low range still improved. And patients with the highest Lp(a) had benefited the most despite less reduction in the Lp(a) level overall. So any reduction seems to be associated with improvement. So the antisense oligonucleotides are hope for the future with Lp(a) reduction. The messenger RNA for ApoB100 drug is mipomersen. It's only available in the United States, and very few clinics are using it. The messenger RNA for ApoA, Ionis ApoA-RX, and Axia ApoA-LRX are still in drug trials, and we are hoping at Emory to get in the one with Novartis. Mipomersen is an ASO targeting apolipoprotein B and thereby reducing levels of all apolipoprotein Bs, whereas the Acacia will target the apolipoprotein A and where it's assembled in the liver, thus acting more like a statin working on the site of production of Lp(a). So it's oxidized phospholipids that really tell us the risk of future cardiovascular events, and the oxidized phospholipid A's, ApoB, are associated with angiographically determined coronary disease. I thought that would be very interesting to the interventional cardiologist on line with us today. It predicts the presence and progression of carotid and peripheral artery disease. It's a novel biomarker for diagnosis and prognosis of calcified aortic valve stenosis, and it reflects acute coronary artery syndromes. It rises with percutaneous coronary interventions and is excreted from oxidated phospholipid-rich vulnerable plaques. It's used to predict death, MI, stroke, and peripheral artery disease in prospective primary and secondary prevention trials. It enhances the predictive value of the Framingham risk score and the Reynolds risk score and reclassifies up to 40% of patients, and provides independent predictive value above and beyond Lp(a) plasma levels. And the results are independent of elevated CRP. So this is a graph showing the ISIS ApoA ASO drug, and as its levels increase, we see the reduction of Lp(a), but also oxidized phospholipid ApoB and oxidized phospholipid ApoA. And as the levels wear off, the levels of the phospholipids increase again. Another recent study that was published in the European Heart Journal just in the last week or two showed that not only do the ASOs reduce Lp(a) very potently, they reduced inflammatory markers, whereas the PCSK9s, they have a modest reduction on Lp(a) while having a very nice reduction on LDL, but don't seem to work on this inflammatory portion of what Lp(a) is associated with. So what are the controversies with Lp(a)? Well, for years, people have argued how to measure it in milligrams per deciliter or nanomoles per liter. And the gold standard was nanomoles per liter, but with more important studies and recent studies showing that the difference in the isoforms did not change the risk, more and more people are now accepting the milligrams per deciliter. There are isoform changes, but the studies have been showing that it doesn't matter about the isoforms, that all elevated Lp(a) is associated with increased risk. Lp(a) levels do change. I did say that it's a genetic marker, so you could check it once, but there are certain areas where it can be changed, and it can increase in patients with familial hypercholesterolemia, in pregnancy, in patients with inflammatory disorders, and rheumatoid disorders. I already went over how it increases at menopause. It can change with hypothyroidism, chronic renal failure, and nephrotic syndrome. So keep those in mind, that it will be higher in those situations. It's decreased with, and I'm sorry, nephrotic syndrome should not be there. It's decreased with severe sepsis, estrogen, and testosterones, and that makes sense with the HERS study. It decreases with biliary obstruction, severe liver disease, LPL deficiency and LCAT deficiency, and with very high triglycerides. So let's go back to our clinical cases. Our white male who's 54 years old with a strong family history, very elevated LDL, worrisome for FH. He's had good LDL running from 70 to 100 with his statin. Calcium score was low, but were we doing enough? Well, when we checked his Lp(a), it was 154 milligrams per deciliter, markedly elevated. His HDL is also not favorable at 31, and his ApoB is higher than we would want at 90. So he is still at risk. And based on this improved data, it was decided to put him on a PCSK9 inhibitor, which would markedly lower his ApoB and help reduce his Lp(a). In our African-American female, who's 41 years old with a very strong family history and fairly good LDL, HDL, and triglycerides on her own, when she was checked, she was 105 milligrams per deciliter. This was felt because it's an enhanced risk factor that she was at higher risk, and she was started on a statin after shared decision-making, patient-physician discussion on the risk and benefits. Just so you know, there are ICD codes for having elevated Lp(a), and it's very important for us to use these, especially if we want to enroll patients in the upcoming ASO trials. So I encourage you to take an extra minute to add these codes to your EMR and use them when appropriate. Also, in the time of COVID, I looked for something that might be interesting to Lp(a) because I thought this talk might seem not so important with what's going on in the world. Well, Sam Semikis is a giant in the Lp(a) world as far as clinical and research trials. And he put this letter out on social media saying that for patients with elevated Lp(a), they really needed to be worried and concerned during the COVID outbreak because Lp(a) is a lipoprotein associated with both cardiovascular disease and thrombosis, and the Lp(a) levels may rise substantially in response to the IL-6 levels, and that the cytokine storm accompanying COVID-6 is manifest by increased IL-6 levels, which may further increase Lp(a) and add to additional cardiovascular complications in these patients. So I'm not expecting any of you to draw Lp(a) levels on your COVID-19 patients, but for those patients you are already treating with it, keep in mind that they are possibly at even added risk to have decompensation in this cytokine storm. So in summary, Lp(a) is an important independent risk factor for cardiovascular disease as well as calcified aortic valve stenosis. It's entirely genetic, so it's really important to check it with family history. It has 3 important markers I want you all to remember. It is pro-atherogenic, pro-inflammatory, and pro-thrombotic. It can help you with risk stratification for intermediate risk patients for determining to be more aggressive with their clinical and medical treatment. And it's generally inexpensive, quick, low risk, and generally only needs to be tested once. So I'll stop now for Q&A.
Okay, great. Thanks so much, Dr. Lundberg. And if people have questions, you can unmute and you can either text me or here we have a question. Do the current studies with antisense drugs include hard clinical endpoints such as death MI, or are they focused on LPA levels?
They're
Dr. Taylor.
definitely looking at clinical outcomes, risk reduction and events, and also safety and efficacy. So they're not just looking for Lp(a) reductions, but hard outcome improvements.
So are you ordering Lp(a) on everybody?
Not on everybody, no. So sometimes you'll see a patient that comes in with a, family history, mom, dad had a heart attack before 60. And when you start asking about them, they didn't smoke, as far as they knew, they didn't have high cholesterol. Those types of situations where you're actually hunting what could the risk in the family be, I think it's useful there. I order it in all FH patients or suspected FH patients because their vascular disease burden is so much higher if they have both, and they need to be more aggressively treated. When I have a patient who's on optimal medical therapy and has a second event, I check for that. So I use my clinical schemata to decide who gets it. I do not do it on everyone, and I'm not sure everyone needs it. That's certainly not what I was trying to say today.
Well, the European guidelines have added this as, something that everybody should get checked at least once, at least my read of it, the recent ones that were released in 2019. But I know that the ACC-AHA guidelines have said to use it as a risk enhancing factor.
Right.
Here's another question. I'm not sure who it's from, but if there's high non-HDL, do we need Lp(a)?
Yes. So that's one of the things I was trying to point out in several of the slides is even with low LDL cholesterol, which would mean a low ApoB, you still have risk if you have elevated Lp(a). So until you can't really tell someone you're low risk until you know they don't have elevated Lp(a).
So if somebody has, I saw that on your list, there was niacin that helps lower Lp(a) currently, and possibly PCSK9, but those are so expensive. So if you have a patient who has normal LDL levels, high lipoprotein A, do you recommend niacin?
I never recommend niacin anymore. There's just too many good studies. And like I showed you, AIM High, Arbiter 1 and 2, they really show that while the Lp(a) number goes down, the outcomes are not improved. The only drug that has shown any real benefit is estrogen in the HER study. So no, I don't recommend niacin. It's over the counter. Patients get it on their own. They do have elevated liver enzymes. People have even had liver toxicity and failure with it. It causes flushing, a lot of unpleasant side effects. So no, I really do not recommend it.
Okay, and I have a question here from Shushmita. She's texted me. Do you follow lipoprotein A levels on statin treatment?
I don't. One, they are going to go up a little bit, and we don't know that that's even clinically meaningful. So the current thinking is lower the LDL as low as you can, because of course Lp(a) is an ApoA attached to an LDL, to an ApoB, and you have to lower the LDL. Once we have drugs that will target both, I think we'll see, nice results with that. But for now, I don't keep checking it. It's going to go up. It's a genetic marker, so there's no reason to do it more than once, and it makes patients very anxious. So I don't.
Mm-hmm. Okay. Here's another question from Dr. Taylor. Does the lack of effect of niacin make you worry about the ASO studies, that they will also be negative? Is it not possible that Lp(a) could be a marker but not causal?
Well, the ASO trials have been out in phase 2 and they're now in phase 3. And If I had had more time this morning, I was going to show you some of that information. It's actually at the end of my slide deck if you want me to send it to you, but they are showing improved outcomes. And so I think it's very optimistic and hopeful that it will. There's also studies ex vivo showing reductions in inflammation, as I showed you, as well as LP little a level. So it could be that it's more of a marker for multiple things, the atherogenic, inflammatory, prothrombotic factors of this, but the ASO studies, particularly the phase 3, are looking very positive, and we were hoping to have some of that information at ACC 20 that didn't happen. So we'll see what we hear at AHA, if it happens.
Mm-hmm. What are your thoughts about, patients who have rheumatologic or lupus or RA? Often they have paradoxically, kind of low LDL levels, although they're at high CVD risk. And I was wondering if you had heard about, LP little a specifically in that population.
Other than the fact that it's increased in that population, no, but it might help explain part of why patients with rheumatologic disorders have even more atherosclerotic burden than non. So it could be that this is an additional risk factor in them. If I have a patient with a rheumatologic disorder, especially one who was trying to avoid a statin, because they already have aches and pains, they don't want anything that even might give them more pains, I do like to check an LP little a level. And if it's low, I feel more confident going with something like a well-called Rossettia in them. But if the LP little a is really high, I feel like they need a statin, and I encourage them to at least try it and see if they get musculoskeletal side effects.
Okay. Here's another question from Dr. Sherman. Are ASOs injected? And if so, how often?
So the study that's that was announced last year, it's a twice-a-year injectable, and it's not just an injection, it's really an infusion, like it's a bag that's hung. And so these patients would come to the office like their every 6-month visit. They would get their infusion, get their labs checked, and then the medication works long-term. So yes, right now they are infusions. Well, thank you very much. And if any of you have other questions, let me know. I'll be glad to send you the full slide deck. There is more information. I just didn't have enough time.
Okay, great. Thanks, everyone.
The preceding program is copyrighted by Emory University.